Hi everyone, this is Chris and welcome back to Chapter 11. We're going to get into an example of how to analyze a 12-lead electrocardiogram. So this electrocardiogram happens to be one of my heart, and you can pause the video and take a look at that at your discretion. Okay, so what we are looking at is 10 seconds of analysis with a standard calibration, and that's what those green highlighted areas indicate. So every time that you analyze a 12 lead, you should make sure that that icon is two large boxes tall, indicating 1 millivolt, and one box wide, indicating that the speed is moving at 25 millimeters per second. So what that means is you've got four consecutive 2.5 second strips, all right, 1, 2, 3, 4, and they are precisely 12.5 big boxes wide each, or 50 total for the entire 12 lead, or 62.5 small boxes wide, again, each one of those sections, or 250 total. If I come over here, the print on this is a little bit faded, but you can see this 25 millimeters per second. Each one of these little squares represents 1 millimeter. So in a 10-second strip, you can imagine that you're going to have 250 small boxes. All right, just to kind of help you understand what you're looking at and the timeline. And 10 seconds is a long time for the analysis, and that's why it's important for your patient to be relaxed, breathing normally, and not moving around. All right. So remember to do your individual rhythm strip analysis first. So we do rate, rhythm, P waves, PRI, QRS width, and then interpret the individual rhythm first. Okay. So we have blown up a couple of these images and just kind of highlighted some of what the machine interprets as well. So I got a rate of 63. If you count the boxes up here, you get 24 boxes into 1500. Comes out to 62.5, so rounding it up. And you can see it's covered by this, but I'll take that away. You can see the machine got it at 62, so pretty close. And the rhythm is regular. If you count a few of these, you'll see they're 23 boxes apart. There's one or two of these that's 23 boxes apart, but that's only one box in deviation. So remember, you're going to call that regular. The P waves are normal. All right, so you have to look at lead 2. You've got these upright P waves that are the same. Because the rhythm is only 62, we don't have a whole lot of data as far as P waves go. But if you look at each section, the morphology of the P waves is identical for each complex in each respective area. So I identified that as normal. Moving on to the PR interval. You can see here the PR interval starts to go upward about halfway over from this box. Then you have one full box, another full box, another one. So it's about 3.5 small boxes. We come over to this one. Again, you can see it starts to go up in this box. So you have 1, 2 full boxes, and then about a half. It starts about half, a little more than halfway up here. So it's precisely measured at 0.134 seconds by the computer, and I got about 0.14. We don't need to go to a thousandth decimal with individual rhythm strip recognition. For the QRS width, again, they have 0.09. When I look at this one, I get 0.08. But if you look at this one here, you can see it starts to go up in this box here, and the transition occurs. This is where the J point would be, right where that arrow is. You can see that's just slightly outside this box too. So I don't quite have 2.5 boxes, which would be a QRS of 0.1, but I do have a little bit more than 2 small boxes. So I called it 0.09, and the machine gave us 0.096. All right, so all of that put together is a rhythm interpretation of sinus rhythm. Remember, we want a PRI of 0.12 to 0.20. So we are well within that range, and we want a QRS width of less than 0.12. And we are at precisely 0.096. So we are well within range there. All right, so good news for me, right? Moving on to the interpretation that is specific to a 12 lead. We are going to focus first on ST segment elevation or depression. And remember, this is where we want to be systematic and look at it region by region. So pick an acronym and stick with it. Either I see all leads or Sally are a couple of examples, but there's other options out there. Whatever you decide to use, just use that same thing every time. So we're going to use I see all leads. You can see I have those blue arrows are indicating the J point for each specific area. So you can pause the video and look at that and just kind of make sure that you understand identifying the J point is crucial to determine if there is ST segment elevation or depression. All right, so we are going to use IC all leads, meaning we start with the inferior region. There is no ST segment elevation or depression in those areas. Moving on to the septal region, same deal. You do see some slight ST elevation. It's minimal, but remember, it's a normal variant for males to have some ST elevation in leads V1 through V3. That is indicated in the textbook and much of the literature. All right, V3 and V4, we're getting into the anterior region. Again, no ST segment elevation or depression. And then we get into the lateral regions, V5, V6, AVL, and lead 1. All right, so looking at these two complexes up close, you can see the isoelectric line in lead 2 over here, and then the ST segment right there are identical, all right? And your ST segment begins there, the QRS complex ends right there, so that would be the J point. And then over here, your isoelectric line is there, and then our ST segment on the way to the T wave is slightly elevated. Again, a normal finding, often with leads V in the precordial leads in the V1 through V3. All right. So remember to treat your patient and not the monitor, and understand the norms that that are out there. By all means, though, if your patient is complaining of chest pain and you see that, it doesn't really meet cardiac alert criteria because it's not quite one full box high. And depending on your protocol, depending on where you work, some protocols might want 2 boxes, 2 small boxes of ST segment elevation for cardiac alert criteria. All right, moving on to the rest of the analysis. So those blue arrows identify the J point in those 2 blown up boxes. Moving on to the next phase of analysis, we look to see if we have a bundle branch block, and that we're looking at QRS width. We've already done that with our individual analysis, so we know that there's no left or right bundle branch block because our QRS complex is narrow or normal. All right, so moving on to atrial hypertrophy, we're going to focus on lead 2. We can also look at V1, but focusing on lead 2, you can see that we do not have a P wave that is more than 2.5 boxes tall or more than 3 boxes wide. So we have a normal P wave, no indication of atrial hypertrophy. And moving on to ventricular hypertrophy, we're going to look at the larger of V5 and V6. Okay, so we are this focuses on left ventricular hypertrophy, and we're going to look at V1, and we're going to add those two together. So with V5, I counted 16 boxes high, and V1, I counted 12 boxes deep. That adds to 28. So we do not meet criteria for left ventricular hypertrophy. Remember, for right ventricular hypertrophy, you can look at V1, and V1, if this R wave is taller than 7 small boxes, that would be an indication that the person might possibly have right ventricular hypertrophy. So we are nowhere near that. And then we get into the axis. All right. So again, remember, you're going to look at leads 1 and AVF. Get your thumbs up. All right. Lead 1, lead AVF over here. And in this case, they are both upright. So we have a normal axis. And you can see that I circled it at 63 degrees. Just a quick recall of axis. We are using the 6 leads that are identified in that picture. So we were looking only at the horizontal plane. My axis was 63 degrees, and so my AVL axis would be negative 33 degrees based on that. This is just for your personal information. It's not something that you need to know or have memorized. But if you're looking at my 12 lead and you're wondering why is AVL so flat, why is there no amplitude there? This explains why. Because the direction of that vector of electrical activity is going 90 degrees away from lead AVL, approximately 90 degrees away, and therefore it's flat. It doesn't really show much amplitude. All right, so additional considerations that are mentioned in the textbook, you talk about QT interval. So my QT interval is identified as 0.378 seconds. Remember, the QTC is a corrected QT to account for speed. We won't get into that with this video. It's something that you can look up on your own, but it's very interesting. So my QT interval is 0.378 seconds. And if you look at the distance here from the beginning of the QRS complex and to the end of the T wave, it looks like it's 9.5 boxes in width, 9.5 times 0.04, and you get 0.38, which is very close to this. Okay, so normal for males, the QT interval, you want to be less than or equal to 0.43. If it's greater than that, it's considered a long QT interval. And just based on research, females get a little bit more leeway, so to speak. If a person has a long QT interval, it puts them at increased risk of having a cardiac event. So you have to be careful about certain medications that you administer to those patients. All right, moving on to the next one is your R wave progression. Very simply, look at lead V3, and if it is 3 boxes or more in height, it indicates that the person has a normal R wave progression. And remember, in and of itself doesn't mean a whole lot, but if a person has poor R wave progression combined with symptoms of acute coronary syndrome, it could be an indication that they are having a heart attack or there is an evolving heart attack. So it is something that you want to look for. The next thing you do is analyze the T waves. So you're looking for inverted T waves. You're looking for T waves that are depressed with a ST segment that's depressed leading towards them. These are things that could indicate ischemia. Some people have inverted T waves as a normal variation. You can see the ones that I circled there are actually peaked and a little bit tall. Maybe I had a little bit of an electrolyte imbalance that day. Sometimes people have tall T waves because they have hyperkalemia, too much potassium. But without anything else going on, that could be a normal variation as well. So the last thing we look for is pathological Q waves. And I'm kind of glad this showed up, with it being my 12 lead, obviously I want to look at this really close, but you can see that by itself looks like it could be a pathological Q wave. In other words, deeper than 1 box, and it's deeper than relative to the R wave that's next to it. But you can't just look at one individual complex. You have to look at the whole thing. So when you look at those other complexes, it really does not meet the criteria for a pathological Q wave. In addition to that, because it's AVL, you look at lead V1, there's no Q wave there. And then you look at V5 and V6, kind of the same deal. So make sure that you're looking at the 12 lead in totality when you are considering any of those factors that might be involved with pathology. All right, so our interpretation, there it is. It's a sinus rhythm, otherwise normal EKG. And use these steps. Be meticulous with your chapter 12 practice. Make sure that you go through these one at a time and become proficient at being systematic with an analysis of your 12 leads. All right, take care.